Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Sorry for the slight delay. Is everyone here already?
Ada 6% Doktor.
How many are you in the batch?
Supposedly 146.
146. We just had a session with Prof. Ramli earlier on. Ada ke tak?
Ada Doktor.
Okay, alright. Okay, sekejap saya tengah set up certain slide. Okay, alright. How's everyone? How many of you are in campus?
Around 30.
Around 30 in campus. The rest is at home. Okay. We shall start our session with Kitab Al-Fatihah. Okay. All right. Assalamualaikum warahmatullahi wabarakatuh. Once again, thank you for being here today. So today's topic is actually the first lecture that you will have for the introduction to psychiatry weeks that you will have this week and next week. 2 minggu kan you all have this session for you have psychiatry for 2 weeks, right?
3 minggu Doktor.
Oh, 3 minggu. So they stretch it to 3 weeks. And I don't think this is supposed to be your timing to start psychiatry yet, according to the original timetable again. So because of the modification due to whatever that has happened now, we have shifted it earlier. So I think nevertheless, get it done anyway. I know you still have some other posting that you haven't done for the rest of the year. When are you expected to finish year 4 anyway? Kalau according to the original timetable.
Kalau original timetable supposedly bulan 9 dah habis Doktor, September.
Okay, September. So apa yang you haven't completed yet? Apa yang pending? The posting that you haven't completed? According to groups.
According to group Doktor.
Half of block 3 dengan block 4.
Half of block 3 and block 4. Okay. So once finish dengan psychiatry 3 weeks ni, the plan is for you to go back to the remaining block 3, block 4.
Yes.
Okay. Alright. And the remaining two are meant to be face-to-face teaching.
Yep. 2 weeks of revision period, then 4 weeks of year block 3, and then exam, and then block 4.
So I know it has been difficult, in particular for your batch, given that you started the clinical years with pandemic last year and then carry on to this year. But one thing that we have to always keep in mind is whatever that is in life, there are things that within our control, there are things that beyond our control. And so let us all focus on things that within our control, and so that we can concentrate and put on our effort to things that are within our things that we can do. And so one of the things that you can do is to complete the posting with psychiatry. So hopefully you'll gain something throughout these 3 weeks. But I'm not that worried, because anyway you'll get another chance to learn and pick up knowledge and skills on psychiatry in the upcoming year once you be in your final year, inshallah. So let's take this 3 weeks as a slow and steady ta'aruf and introduction to psychiatry, inshallah. Okay, I'll share my slides. We have the session until 11:15 kan?
Betul.
Betul Okay. So I've given Cik Alif links to a couple of videos. Basically, those are introductory videos that I would normally give to year 5 during the beginning of the uh, during the beginning of posting for each blogs lah. But I think some of the things that that I've covered in those two introductory topics are fundamental before you embark on your understanding of psychiatry, and because you'll be exposed to a lot of theories, diagnostic criteria, um, uh, behind various psychiatric diagnoses. And so to some, it might be confusing to begin with, and to carry that all within 3 weeks, sometimes it might be hard. And so one of the ways untuk kita to help us to gain better knowledge and understanding of every new topics that we'll cover adalah by starting it off with understanding the bird's eye view of the posting or the new knowledge, okay, to have a broad idea about what it's all about, okay. And so later on, then only you enhance your knowledge layer by layer within that topic or within that discipline. So you start off with creating a framework. Where is the border of this discipline, what it covers in general, and what are the basic principles behind the discipline. And then later baru you include the details knowledge of each subtopics under that discipline. So that's how you start. Otherwise you get lost, okay? So imagine that you are in the middle. So imagine someone drop you in the middle of the jungle somewhere, and hoping by the end of the 3 weeks, you should be able to go back to the nearby village, for example. So how do you start? And so you have to start off with screening the areas and try to get a sense of where you are, and try to get a sense of what are things around you. And so this is a hills, this is a river, things are everything, north is that way, south is that way. And so then only you can start slowly picking up your pace and to your destination. And so that's how every single discipline should be started, and that's how I want you all to learn psychiatry anyway. And so get understanding about general overview of psychiatry first. And so my topic today is also something that I've included in my YouTube channel. I've given it in the free. I've recorded my session for the previous years, but for this year, given that you haven't had, you will not have other session with me on face to face, and so I'll take this slowly with you, all of you, and so that if you have any questions pertaining to the topics, then you can ask it right away. So we'll go through this slowly. We have roughly around 2 hours to cover this topic. At any point, if you have any questions, or if any things that you want to touch on or comment on, just feel free. Either use chat area or ask straight away lah. And so maybe Cik Ali can help me to inform me if there's any notes or any comments on the chat area lah. But otherwise, you can hear me well and clear, yeah? Not the problem.
Yeah,
Clear, Doctor.
Okay, so I'll cover 2 topics. First one is interview techniques, and second one is history taking. And why do we cover psychiatric interview techniques and history taking? And basically, this is your basic skills or tools that you need in order for you to master psychiatry from clinical perspective. Okay, so you don't need clinical interview and history taking to understand about topics in psychiatry that you'll go through in lectures and seminar for this year, but you'll need the skills when you want to apply it clinically. And so once you get the chance, hopefully next year, to see patients, and so whatever knowledge that you have will not guarantee that you'll be able to pick up diagnosis and management from patients. And because what you learn in lecture will not be exactly the same as what you go through in your clinical experience. And so take it like you are having a driving lesson. And so mastering driving lessons and passing theories of driving lessons will not guarantee that you'll be a good driver. And you will only be a good driver once you pegang the steering and you touch on the steering, and you'll be able to go on the road. And some of you might calarkan kereta here and there, langgar anak kucing, langgar anak orang sini sana, and until you become master in your driving ability, in driving skills. Hopefully not lah, tapi maksudnya you can only learn some skills by practicing it in real life experience. And so that's what clinical is all about. That's why we want you to be exposed to patient. We want you to have face-to-face session once everything's sorted, once everything's settled down. You also want to dah vaksin ke?
Ada yang belum.
Okay.
Dan belum.
You all akan vaksin through university ke? You guna standard Mas Sejahtera like any other citizen?
Kalau yang kat kampus tu mungkin boleh ikut universiti, tapi yang kat rumah memang kena tunggu masa sejahtera.
Okay, so yang in campus semua dah vaksin?
Belum.
Belum juga. Okay, alright. Okay. Tapi ada, is there any macam specific list ke atau forms ke yang you all kena fill up untuk request macam special track ke, ada ke?
Ada isi survey form tapi tak pasti tu berapa. Tapi dia pasal vaksin lah.
Okay, alright. Tak apa. Saya tanya je, saya bukan orang atasan, saya lecturer marhain saja. I cannot guarantee you anything. I'm just wondering lah if that's what it takes for you to come back to campus, maybe that's what needed to be done lah. Okay, tak apa. Let's come back to this and focus on topics that we have. Okay, so what we'll cover during this topic. The first one is why does it matter? Why it's important for you to understand about interview techniques and history taking skills? How is it done? And what do we cover when it comes to interviewing patients? And then the troubleshootings related to history taking, and when you face with challenges, what are the common challenges and how do you face those challenges? And a little bit of homework at the end, and hopefully to strengthen your knowledge with regards to the topics that we'll cover today. Okay, all right. So let's start with some some thoughts and for you to ponder. And imagine if lab and radiology department were closed down for good. Okay, so hopefully this will never happen for the rest of our life of mankind, hopefully. But imagine you are in a situation where maybe lab and radiology department were not available for whatever reason. So imagine you're working in hospital of Womusang, for example, and you were cut off maybe due to extreme flood along the way, and so you can't transfer your patient to Kuala Krai or Kota Baru, and you cannot get access to radiology input from Hospital Ipoh. If you use the other way around, so you're stuck in Hospital Womusang, and you have a patient come to you with neurological deficit, and patient collapse and weakness and on one side of the body, and associated with hypertension, for example, came to the hospital. So what would be your thinking? What do you think are the possible cause of this presentation? Anybody? So you have maybe 65 years old Malay gentleman with underlying hypertension, diabetes and cholesterol came with you, collapse and low GCS, presented with one-sided weakness, maybe 1 out of 5 all side. Okay, so what are your thoughts? What are the causes? Sorry?
Cerebrovascular accident.
So you were thinking of cerebrovascular accident. Why?
Because with the underlying diseases and also the presentation, there's a sign of something wrong with the upper part of the brain.
Upper part of the brain. Okay. So upper motor neuron. Okay.
Yeah.
So given the presentation and the history, you have some rough idea that if you want to invest your money in one particular area, so you want to invest your money on the brain, because you think the problem is related to brain, not orthopedics, not ONG definitely, and not medical, not surgical. So it's cerebrovascular accidents. So if you were to narrow it down further, what are the possible things that might have happened? So I agree, cerebrovascular accident is one of the common causes of this particular presentation. But what in particular? So cerebrovascular accident can be anything: vasculitis, hemorrhage, stroke. What are the possible causes you think? Anybody? Yang sisters tak ada yang tak dengar suara again? So far saya dengar suara brothers saja. Sisters ada ke tak? Ke tengah duk sidai baju? Dengar kelas sambil sidai baju?
Ada je doktor.
Okay. So apa common differential diagnosis? Apa examples of differential diagnosis you want to suggest? Lah, dia jawab ada je, betul tak jawab? Yang 140 of you here, takkan seorang pun tak boleh nak come up with any ideas. You all doctors in a year time kan?
Ischemic stroke doktor.
Sorry?
Ischemic stroke.
Stroke, okay. So you're thinking of stroke, and stroke ada two types, and one is ischemic, another one is
Hemorrhagic.
hemorrhagic stroke. Okay. Now, your task is, I do agree, this is the most likely two potential causes of this one-sided neurological deficits in this 65-year-old. So how do you distinguish whether it's ischemic stroke or hemorrhagic stroke? How would you differentiate whether it's a hemorrhagic stroke or it's a ischemic stroke?
CT scan.
Sorry?
By looking at the CT scan.
Okay, true, pretty. And so you need to have some sort of imaging in order for you to look what's happening inside the brain. And so if there's a blood everywhere inside the brain where it's not supposed to be, now you know it's hemorrhagic. If there's no blood, but what you see is a dead tissue, then it's ischemic stroke, and something's blocking the blood vessels and causing ischemic in the perfusion area. So you know for sure it's ischemic stroke. Great idea, but now the problem is your hospital has no CT scan. The closest hospital where you have CT scan is 100 kilometers away, and there's a flood in between. Okay, and so you can't reach that. So macam mana you nak differentiate whether it's a ischemic stroke or it's a ischemic stroke or it's a hemorrhagic stroke? So my first question is, why does it matter for you to differentiate whether it's a ischemic stroke or it's a hemorrhagic stroke? Stroke is stroke. Kenapa? Why does it matter?
Different in management.
Okay, in what way would it be different? Siapa ketua kelas eh? Siapa lah Cik Alif? Cik Alif, if you have name list of the students for your batch, can you forward to my WhatsApp? Saya nak sebut nama ni, kalau tak memang tak berjawab. Setiap soalan delay 1 minute nak menjawab, habis menunggu saja. Okay? What would be the difference in the management? Apa tadi jawab tadi? Boleh sambung? Apa beza dia? So I agree, and both are stroke, but you have to identify the etiology because different etiology have different management. So in what way is different?
If hemorrhagic stroke, we need to stop the bleeding. We need to find out the source of bleeding and then stop the bleeding. Kalau ischemic stroke, maybe we can give anticoagulant, antiplatelet to stop the progression of the
Okay, agree.
To stop make it worse.
Okay, agree, and very true. So essentially, the management are different in a way. One type of etiology, you want to stop the bleed. Okay, the hemorrhagic, you want to stop the bleed. On the other way, on the other side, the other pathology, the other psychopathology, the other etiology, which is the ischemia, you want to embolize the clot. You want to make them bleed, okay? And so one is making them to bleed, another one making them stop bleeding, okay? So this is where your determinant ataupun your decision about the etiology of the disease process that happened to this 65-year-old is highly critical. You have two types of medication to give. One to stop the bleeding, another one is to encourage bleeding. And this is basically to embolize the blood clot. So you have two pills in your hand. Which one would you want to give? And so ideally, you want to see CT brain on the other hand, and so that you can decide, so this is bleed, this is hemorrhagic, then you can decide what medication you want to give. But in the situation that I've given to you earlier, you don't have that luxury of having having a window to peek into this patient's brain in order for you to decide apa yang berlaku within or inside the brain of his poor patient. And so what options do you have? You have to decide anyway. You don't have plenty of time. And patients are not going anywhere. You don't have helicopter available in hospital Go Musang for you to transfer patient elsewhere. So you have to manage them now. You have the medication available. You have the patients available. So what option do you have? So how else do you want to do it?
Try to differentiate from the history and physical examination.
Okay. So
first to differentiate between the two. So from the history, if we suspect ischemic stroke, we try to see any risk factor that the patient have. For example, obesity. Example, high lipid intake and so on. That we try to differentiate in terms of history. Okay. And if it's not possible, when we try to do physical examination, try to find symptoms. This one maybe I'm mistaken, tapi for example, if hemorrhagic stroke, try to see if any possible source of bleeding. Kalau externally any possible source of bleeding. So try to palpate that possible space. Allow, since doktor kata radiologi tak dapat, kalau ultrasound pun tak boleh, kalau boleh try to do fast scan, try to see any possible bleeding lah. Kalau
macam mana you nak ultrasound the brain sampai?
Tak hemorrhagic stroke. Ya. Okay.
Sekarang ni, okay, we work out this case together, okay? So we have 140 of doctors in the room. So there must be someone yang will come up with one brilliant ideas and solution to this. Otherwise, patient ni akan die in the hands of 140 doctors. Batch apa nama? Batch you nama apa? Apa? Avanzoa. So you don't want people to remember Avanzoarians ni as 140 doctors that kill 165-year-old patient, because none of them were able to answer, none of them was able to provide solution to this problem. Okay, so you have 65 patients lying on the bed for you. So ideally one CT scan, but no one will be able to come up with that, and unless all of you can put your brain together in building up new CT scan within that couple of hours, it will not happen. So we put investigation aside. So what we have is going back to basic, and so basics that we have. So basic that we have now is starting from history. So you don't have investigation, so you have to go back. You step backward and start back with the history. All right. So with the history, and you have to decide what are the things you want. You want to know patient's favorite food ke? You want to know patient's hobby ke? You want to know patient's housing condition ke? You want to know patient's pets names ke? You have to decide with the history, what do you want to know? So Samba tadi, betul kan? Samba yang jawab tadi kan? So Samba have given some ideas about what he wants to know. So he gave a history that he gave suggestion that maybe we can ask patients about their punya risk factors. Do you have diabetes? Do you have hypertension? Do you have cholesterol? So patient said yes to all of those. So dia ada diabetes, hypertension, dia ada cholesterol. Now, would that answer help you to differentiate whether it's ischemic or hemorrhagic, Samba?
Yes. It increase the possibility that it is ischemic.
You think so? So what are the common causes of hemorrhagic stroke? Why do patients have hemorrhagic stroke?
Aneurysm, I feel.
Uncontrolled hypertension.
Okay, so one is aneurysm, maybe congenital, and second one is hypertension. So patients have hypertension. So what are the common association of hypertension? Diabetes, cholesterol. So by knowing that patient has diabetes, hypertension, and cholesterol, actually does not make it easier for you to differentiate whether it's ischemic or hemorrhagic. All you know is patient have high risk to have a blood vessel disease, correct?
True.
Okay, so blood vessel disease can occur sama ada vasculitis infection, bleeding, pecah ataupun block, and so it still does not narrow down your options now. Okay, so you have few more minutes, cepat, patient nak mati ni. So I give you another 5 minutes. Kalau you tak boleh solve juga, then patient will die in the hands of 145 adversarials. Anybody else? Cepat.
Patient merokok tak?
Merokok tak? Okay, so it's good to know, but will that help?
No.
No.
Do
Okay.
physical examination, check the
Okay.
blood pressure and patient's vital sign. If it rapidly, then maybe it's hemorrhagic stroke.
Okay, so good idea. So when you want to go to physical examination in order to understand about the punya vital signs. So kalau hemorrhagic stroke associated normally dengan hypertensive crisis. So kalau patient datang dengan blood pressure of 120 will not be dissimilar if patient datang dengan blood pressure of 200. Okay, correct. That's one way of looking at it. Let's go back to history. Is there anything else you want to ask in order for you to help to differentiate these two?
For hemorrhagic stroke, basically yang boleh differentiatekan dia dengan ischemic, kita boleh tengok symptom of SOL.
Okay.
Sebab hemorrhagic dia boleh jadi space occupying lesion, di mana darah tu akan terkumpul kat dalam brain, and then dia akan menunjukkan simptom SOL macam projectile vomiting, severe headache.
Okay. Alright, good. Siapa tadi tu? Aiman. Very well done, Aiman. So, so before you go on to physical examination, always remember that there are still things that you need to gather from the history that will help you out. And so one of the things is you are looking for associated symptom. So both hemorrhagic and ischemic will give rise to stroke. Okay, so do not concentrate on things that are commonly shared by these two. So you know patient had a stroke, witness kat sebelah mana. So of course you have to ask that. But now your task is not to confirm patient ada stroke atau tak. Your task is to confirm what kind of stroke the patient ni ada. And so one way of looking at by looking at associated symptoms. So these two are the common complication, and which is neurological deficit, tapi dia ada different set of accompanying symptoms. So of course with hemorrhagic stroke, dia associated dengan space occupying lesion because ada bloods in the brain, and so you look for associated space occupying symptoms. And so terrible severe headache and vomiting, dizziness. So bila patient presented with that gives you some ideas. It then sounds like ischemic. It is more like the ischemic, but I need more information to strengthen my hypothesis. Okay, good job. So, anything else? Anything else in this? Cepat. Time is ticking.
Ada ambil anticoagulant tak?
Ada apa?
Anticoagulant or antiplatelet that can cause bleeding.
Okay, so siapa tadi tu?
Rifdi.
Okay, so also good thoughts. And so if patients on anticoagulant, and so example patient has had bypass in the past, patient on anticoagulant, patient on warfarin, it's very unlikely patient will develop a clot, okay, within the system. And kalau dia ada clot, it will start with peripheral first. And so it's very unlikely you have something yang central blocking you while at the same time you are on warfarin or any blood thinning agent. So things that you need to ask is actually, are you on one? And second, was there any changes? Whether you increase the dose or you skip the dose. So if you skip the dose, maksudnya you non-compliant to your blood thinning medication for the last 1 month, now you develop this, apa yang more likely?
Ischemic.
Ischemic, good. And so kalau patient on medication, tak pernah skip, develop the symptoms, what's more likely?
Hemorrhagic.
Hemorrhagic. Ataupun at any point, patients confused about the medication, family have given extra amount of medication, and then what is supposed to be, then more likely?
Hemorrhagic.
Hemorrhagic, okay. So now we have some apa namanya, some substance in order for us to make up this case. Any other thoughts? Any other thoughts?
Patient ada sakit jantung tak sebelum ni? Maybe AFib can cause blood clot to be thrombolized to the brain.
Alright, good. And see, you all start thinking now. Kita dah start ada useful and fruitful discussion. So if patients ada underlying cardiac problem, and so that will slow down heart punya kita panggil apa? Heart punya motility, and so they end up kakak. So that will end up slow down heart motility and causing increased likelihood of developing embolic, and then patient akan dapat embolism. So if that's the case, then embolism it is. Anything else? Maybe one more before we move on to physical examination. Come on, doctors. Cepat doktor, saya nak buat apa ni doktor? Tak ada idea. Okay, I'll give you one clue. So another thing. So we've looked at associative symptoms, risk factors. We look at patient's past medical history. So those are things that we cover in the history, yang mana we know it's valuable for our decision making process. Now another one that we need to look at is the onset of the symptom. Okay, antara hemorrhagic and ischemic, both will produce stroke, but the way they present would be different. One condition, I give you a clue so that we'll get things going faster. Kalau tak, kita habis kat slide ni je sampai pukul 11. So one condition, symptom is worse at the onset of pathology. Another one, symptom will worse gradually over time. Okay, faham tak? Okay, kalau in this case, we are looking at symptoms of hemiplegia. Okay, so hemiplegia kita measure based on dia punya level kan. So 0 is no power at all, 5 is normal power. So kita tengok dekat dia punya power. Okay, so one condition at the onset of etiology, dia punya power will go down to maximum. Let's say 0 out of 5. Dia akan stay that way. Tapi another condition, dia punya power akan reduce gradually. Maybe dia start dengan 3 out of 5, and dekat ED 1 out of 5, masuk dekat ward 0 out of 5. So dia progress over time. So which is which? The first one is what? Second one is what? Siapa nak bagi?
Second one is ischemic.
Second one is ischemic. Kenapa?
Sebab dia slowly progress, I think.
What?
Yep.
Balik.
Cuba think about pathology behind those things. Satu block, satu pecah. So the first one is what? Yang terus band 0. Apa?
Yang tu hemorrhagic.
Ya. Sebenarnya tak. Sebenarnya embolic will cause maximum impairment at the onset of symptoms. If you think about it, kalau patient presented dengan block, once they block, there will be no more kita panggil apa? There will be no further. Dia nak worse macam mana lagi? Dia dah block. That's the worst thing that can happen is block, tutup. So once dia block, dia tutup coverage of that area will be dead. And tapi kalau bleeding dia different. So bila bleeding, and so dia akan bleeding, macam bleeding lah. Bleeding dia akan start sikit, dia akan start banyak, and so antara yang berlaku bila bleeding adalah number one, and you have direct loss of oxygen supply to that area, and second, you dapat the secondary impact of it, which is the blood clot yang akan pressure the area, that will also cause another damage, and then you get herniation, you get swelling of the brain, and because of the bleeding, and then you get another compression effect. So if you think about bleeding, and there is a progression of one pathology to another pathology as compared to blockage. So blockage ni dia macam sakit jantung lah. So you block your heart stop pumping, drop dead. And so brain macam tu juga. So you block your area, so whatever area yang cover itu saja yang akan block. Okay, so the cover area occipital, for example. So that particular blood vessel yang block cover occipital. So once the whole occipital area is blocked, the whole occipital area is affected, then the rest will remain the same, unlike hemorrhagic. So this is where, and your history and your physical examination matters, because it helps you to understand what's going on in the brain. And then later you go on to your next step, which is physical examination. So of course, one thing that you do is you do vital signs to check. But even if you do vital signs can be the cause of the problem or the complication of the problem. So for example, is blood pressure drop, and it could be the impact of the shock, or the blood pressure drop causing less supply to the brain. And so vital signs alone will not help you to differentiate. So you need to go back to your neurological examination in order for you to find out what's happening. So now you know the pathology, it's hemorrhagic, for example, or it's embolic, for example. The next thing that you need to know is you need to localize the areas of the brain affected. You ni semua dah buat medical ke belum? Dah buat medical. So takkan ada excuse untuk tak boleh jawab soalan saya. We haven't touched psychiatry pun lagi. And saya nak ajar you medical, bukan sebab saya nak you faham medical, tapi saya nak get you an idea the importance of history taking, the importance of proper history taking and physical examination, in particular in psychiatry. Why? We'll talk about it in a minute. Kita habiskan dulu. Pakcik ni tak meninggal lagi ni. Dia masih lagi duduk dekat atas katil lagi tu, waiting for you to do something about it. So the next thing that you need to know adalah to localize the lesion. So for example, with the history, you tahu dia ada heart problem, symptom worse at the onset of presentation, patients patients not on any anticoagulant, so you know patients ni most likely ada ischemic stroke. So now your task, the next task is for you to localize the area. So for you to localize the area so that you know whether this is something yang severe, need further attention, ataupun something yang minor yang akan you can sort out later. So macam mana, how with physical examination you can localize the area of lesion? You nak localize dekat mana dalam brain tu yang affected. So of course, the ideal way of doing it is by CT scan, but you don't have the CT scan now. So nak buat macam ni. Apa yang you nak tengok dekat physical examination? Saya panggil nama lah. Saya tengok depan atas Nur Izzah. Ada tak Nur Izzah? What do you want to look for in the physical examination?
For physical examination, you can because this stroke possibly. So of course it involves upper motor neuralization. Okay. But then we need to know which branch of the vessel that affected the brain. For example, if we need to know if this anterior cerebral branch, middle or posterior. For example, kalau Anterior, maybe patient have late involvement, so dia akan dapat late weakness macam tu.
Okay.
Kalau middle,
So
maybe dia affected the face, facial expression.
okay. So if you want to narrow it down, you have 3 areas of the brain that could be affected. You have cortical area, you have subcortical area, and then you have your brainstem. Okay, antara 3 ni yang mana yang paling kritikal? Antara these 3 areas, brainstem. Why?
Because dia affect, ada respiratory branch.
Okay, so true. So very true. And so if it's affecting brainstem, that means you need to get anesthesia involved. Patients need to be intubated because the next thing that will happen, patient will stop breathing and different color. Okay, so brainstem. So you have to look for brainstem signs. Okay. Kalau cortical area, and apa yang you want to look for kalau cortical area?
Weaknesses of the lower limbs.
Okay, so kalau cortical area, you have to look for cortical signs. And so there are frontal lobe signs, parietal lobe signs, occipital lobe signs, temporal lobe signs. And so maksudnya, apart from looking at the motor, tone, power, tone, you have to also look at the specific symptoms of the affected lobes, for example. Kalau parietal lobe, apa contoh signs dia? Apa contoh parietal lobe sign?
Hasil.
Sorry? Tak dengar tu.
Ada patient that has aphasia.
Aphasia. Okay. Cuma aphasia ni dia border between frontal and parietal, the temporal parietal. Lagi? Lain?
Sensory problem. Sorry? That has sensory problem.
Auditory problem? Sensory problem, somatosensory problem. Okay, good. So kalau they presented with weakness and numbness, and then you're thinking more of a somatosensory areas. And so you get the idea. And so you have to specify the symptoms. So apart from weakness, what else do you have, Pak Cik? Apa lagi yang Pak Cik ada? Okay, dia ada diplopia ke? Dia ada dizziness ke? Dia ada sensory problem ke? Dia ada finger agnosia ke? Dia ada left-right disorientation ke? So all of those will give you a clue whereabouts in the lobes that will help you to decide dekat area mana yang dia ada. Okay. So kalau dia subcortical and brainstem region area, apa yang you will look for? Apa signs that you want to look for?
Signs, maybe we can see the breathing itself.
Okay. Breathing tu
patient might have dyspnea, so ada sign of the cardiorespiratory distress.
Right? Apa lagi yang ada dekat brainstem? Basically yang breathing tu is much lower down. Atas sikit ada apa?
Cerebellum.
Cerebellum kat belakang bang. Dekat antara subcortical. Dia dah lupa dah dia punya anatomy tu. Pons. Dekat pons ada banyak apa?
Medulla oblongata.
Ada banyak nucleus.
Ada banyak apa? Nucleus. So this is where all your nuclei of your cranial nerves located. Betul tak? Do you remember cranial nerves now?
Yes.
Okay. So this is where you need to do cranial nerve examination. So kalau dia ada motor weakness associated with cranial nerve weakness, contohnya dia ada facial weakness, dia ada gait reflex, loss of gait reflex, so dia ada olfactory deficit, then dekat mana lesion dia? Dekat mana lesion dia?
Dekat brainstem.
Dekat pontine area lah. Dekat so it's a pontine stroke. Okay. Alright. So panjang kita cerita. It took us almost 1 hour to sort out the case. Okay. Tak masuk lagi topik kita ni. So basically, and I want you all to get some ideas and understanding about what lies ahead of you once you become a doctor. Okay. And so I agree, and one of the things that we'll do bila you jadi husband adalah you turun down dekat radiology department, minta CT scan, and then dah dapat result CT scan, tunjuk dekat specialist, and then specialist bagi tahu you nak kena buat apa. Tapi you will not stay that way forever. And at some point of your life, and you'll be given more and more responsibility to manage patients. You become MO, you will transfer to klinik kesihatan, district hospital, where you'll be less dependent on others in making decisions. So therefore, you need knowledge, you need experience, you need skills in order to be a safe doctors. Okay, so that's why we want to emphasize on basic and fundamental things before you go on into more sophisticated things. So fair enough, you want to be neurosurgeon, you want to be cardiac surgeon, cardiothoracic surgeon, whatnot. Tapi let's go back at the fundamentals of medicine, which is history and physical examination, regardless of the system. And you have to master nephrology, you have to master neurology, you have to master cardiac, because patients at the end of the day, once you become doctor, will not come to you with posting. Okay, dia tak akan datang dengan posting. So all patients that datang hari ni, psychiatry patient. All patients that datang minggu depan, medical patients. Tak, they will come with different problems, various problems, some more than one problems. So this is why history taking is important, and in particular in psychiatry. And because in psychiatry, we do not have the luxury of having investigation. Not because we don't have money, but because investigation has not much role at this stage and up until now, and with regards to diagnostic ability. And so the most important part required to diagnose patients with psychiatric problem is your brain, okay, your knowledge, your experience, and your skills that you have within you in order for you to help patients. There will be no other areas of medicine that will help you. The rest will work as an adjunct to your management, but the core task will be from you, okay, and you are required. So 3 essential things in psychiatry, and number 1 is your ability to gather psychopathology. So psychopathology is symptom and signs in psychiatry, symptom and signs of mind, and mental state examination, which is your physical examination of psychiatry. And then from there, and you need to have knowledge in the diagnostic and formulation of psychiatry. So diagnosis is your labeling of the illness, major depression ke, bipolar ke, schizophrenia ke, and formulation is your understanding what are the risk factors, what are the stressor, what are the perpetuating factors for this patient, and later on from there you develop your management. And with management, you need to focus on the biological component, psychological component, social and spiritual input. And so all of this will be decided, will be drawn from your findings from your history. Okay, so that's why it's important to understand the basic concept of history taking and interview technique. Without those, the other 2 components will be flawed. Okay, so this is the important things. So why psychiatry interview is different, even though you know about clinical interview in the rest of medicine? For a reason. Number 1, psychiatric patients are different. Okay, and different not in a stigmatizing way, different in a way that some of them have challenges in explaining the symptoms. So it may be cognitive issues, or it may be because of the illness itself. So if you have heart problem, you have chest, you have pain in the chest, no one will hide that. They will straight away come to the hospital and say, pain here, there. But psychiatric patients are different because the pain that they experience is something that they cannot locate. So they cannot point to you, I have pain here, I have pain there, I have problem there. And so what they experience is unique to them. And so if you cannot help them to identify their problems, you yourself will have problems in identifying patient problem. And second, emotions, which is one of the big parts of problems in psychiatry, may not always readily accessible. Okay, so sometimes people can voice it out right away. I have depression, I'm sad. But there are times where emotions are difficult to access. So for example, you have somebody who has been traumatized by sexual abuse, for example. So they become numb, and so they become mute. They cannot express it. They are too fearful to express what they experience. So you might have trouble. And even though for you it's easy. Tell me what's the problem so that I can help you. But for the patients, it may be difficult for them to express it. So the other day I had a patient, autism, adolescent with autism, presented with catatonic, mute, refusing to move. So we had to carry him all the way from clinics to emergency department and have all investigation done. And so we wanted to know what did he experience inside his mind, whether it's psychotic symptoms, whether it's mood-related symptoms, whether it's anxiety-related symptoms. But unfortunately, we will not be able to do so unless this patient shared what's inside his mind. But because patient was catatonic, we were not able to explore those. And patients with autism, for example, again, I give an example of autism because I run child and adolescent clinic. Some of them have problem with communication. They cannot verbalize. Patient with intellectual disability, patient with post-traumatic stress, patient with post-traumatic brain injury, and also some of them have difficulty in expressing their symptoms. So we need to have knowledge and skills in order to gather information in this. Adolescent patient, for example, may be secretive. They were not keen to be interviewed. They don't want to talk to strangers. They don't want to be in the psychiatric clinic at the first place. So these are some of the challenges that we may experience when we encounter patients with psychiatric problems. So it's difficult, but at the same time, you only have your history in order for you to access the diagnosis, and so you have to work all the way in order to work out your diagnosis. And more importantly, last one, this is something that's also important. Later, when you see patient, you might be able to get a sense of this. Rapport and active listening and can be part of the therapy. All right. So sometimes you might not be able to start your treatment immediately, or your treatment might take some time. Psychotherapy, for example, may take some time for it to start working. But by having someone listening to their problem and by providing opportunity for patients to express their difficulties and challenges in life, that in itself sometimes therapeutic for the patients. And for example, patients who come in a background where they don't have anyone to share their problems. They come from a toxic family. They come from a very abusive family, for example. They have no one that will be able to listen to them. But when we conduct our psychiatric interview properly, and not only asking the right questions, but asking in the right manner, that in itself will be therapeutic for the patient. So for example, those who come with panic attack, for example, panic disorder, anxiety disorder, they might not know that that's actually a psychiatric problem. They thought they have heart problem. They thought they have myocardial infarction that may cause them to die in any moment. But by asking the right questions, explaining it properly to the patients, at the end of the interview, patient might be a lot calmer than before the interview was conducted. So this is important for you to know, so that you can also be part of the therapeutic environment for the patients. Those days when students were allowed to come to Wat Dahlia, for example, and some of the patients are very delighted to be able to spend sometimes with the students. You might be there in order for you to complete your logbook, but for some patients, it might be a good opportunity for them to be able to see someone, talk to someone, express themselves. So you might not know that you will actually contribute something to the patients, but that is one way for you to be able to feel that you are making difference and with your patient even before becoming a doctor. So effective interview is important. So you want to achieve the objective of the interview, which is basically two. One is to establish diagnosis. Second is to manage the patient. But it's also important because you will be able to develop trust. And some patients, you might need a couple of sessions before you get proper history and later diagnose patient. But you will only be able to do so once patient develop trust to you. So imagine you have somebody yang experience a very traumatic life experience, being sexually abused by father, mother who confiding with the father to keep the secret, have siblings who are having a drug-related problem, for example, or patients herself or himself have sexual-related obsessions. So these are the things that are very secret to individuals. And so you don't go around and talk about this publicly, but to talk about this to stranger, to another doctor, and to another medical students who approach them and to clark them. So it's a huge thing for some patients. And so trust is important. And I talk about active listening and effective interview being therapeutic. And another thing, and for you to also remember, is spending time with patients is actually very cost effective. And you might think that it's much easier to call up a radiologist and to do brain imaging and whatnot. But by spending time, spending time and carefully dissect the history, sometimes we save you a lot of money. You might not need expensive surgery if you, at the end of the day, understand that it's actually a delusion rather than the actual problem, rather than the actual physical problem. And so effective interview is highly important, and this is what you need to learn and you need to understand. All right. And one of the things that we want to achieve before we start interviewing a patient is establishing a good rapport. So basically, a good rapport is a distinguished features between us as a doctor, especially doctors in psychiatry, and a police officer. And both may want to get information from patients, but the police officers ke, prison officers ke, may not really bother about getting a good rapport. And because they just want information, once they get information, their job is done. So they're not thinking of seeing the patient again, helping the patient with regards to the psychological impact. But we are not like that. And, not in a bad way, they're doing their job, but our way, our task is more than just getting information. And so how do we develop rapport? And so first one is we have to be genuine and respectful to the patient. And regardless of who this patient is, patient psychiatry, tak psychiatry, they're human beings at the first place. And so we need to be genuine and respectful to them. And so sometimes there are things that we might not notice. And so, for example, and sometimes kita nampak patients tu nampak macam tak educated, mungkin tak not in a fair hygiene state. And bila kita interview patient, kita interview patients macam kita interview orang dekat tepi session bus. Kau buat apa kat sini? Kenapa ada kat sini? Awak buat apa kat sini? Tapi kalau patient tu yang nampak pakai coat, pakai tie, kita berkata, encik, boleh saya tahu kenapa encik ada dekat sini? So that is basically showing that we are not being genuine and respectful. And as a doctors, we have to be neutral and regardless of patient's background. And kita kena apply same professionalism regardless of patient's punya conditions. So, for example, I have patients, adolescent patient with borderline personality disorder and depression, and frequently coming to emergency department because self-harming behavior. So they cut their punya wrist whenever they feel distressed. And so one time they came to me following dia punya episode of self-harm, and they share with me experience. Dia kata, masa saya pergi emergency hari tu doktor, and masa one of the staff, let's not name the profession, but one of the staff who were cleaning dia punya cut dekat dia punya wrist, bagi tahu dia cakap apa? Dia kata, dek, lain kali kalau nak bunuh diri kena potong dalam sikit. Jangan potong macam ni tak mati. Okay, so I heard this confirmation. I'm not surprised. I've heard that being spoken, especially in a non-psychiatry setup towards psychiatric patients. So this is something yang very, very, very damaging to the patients. And you might think that your words is basically is meant for the patient to toughen up, but that's not the way to go. Okay, and what you do probably more damaging to the patients than healing the patients. Okay, so you have to be genuine and responsible, and so start with a proper welcome and introduction, because basically patients are there for you to learn. Okay, so they are doing a huge favor to you. Patient have schizophrenia, and just for you to learn something about schizophrenia, if you think about it, the patient bukan choose to be schizophrenia so that you can clark the patient. But if you think about it, if none of them becoming schizophrenia, you have zero knowledge in schizophrenia. But because Allah's chosen them and to experience those challenges in life, so you had the ability or you had the chance to clerk the patients to learn something about schizophrenia. So basically patients are doing a huge favor for you. To become a good doctor, you need knowledge, and the knowledge comes from what they provide to you. And so you owe them instead of them owing to you. Okay, so your body language is important, and so sometimes we'll talk about body language in a minute, but sometimes your body language, patients can tell the body language, and you are not being respectful to them. And so your gestures, your voice intonations, your sounds, your eye contact, all contribute to patient's conclusion, impression, whether I want to give my report to this student or to this doctor or not. Okay, and so that's important. Asking patient's background is also another important small trivial steps that's actually good to develop rapport. You pernah experience pergi GP, masuk-masuk you tak sempat duduk lagi dia dah tanya sakit apa, and so we don't want you to be like that. And so I don't want you to copy manners yang tak professional, even though it comes from the best doctors in town. And so you have to be humane, and orang datang you tak kenal, and jemput duduk, nama siapa, daripada mana, oh ni siapa, datang dengan siapa ni. So those are small things yang sebenarnya help us untuk build more rapport with the patients. Okay, so imagine somebody datang ke GP sebab dia suicidal, dan belum duduk lagi buka pintu terus dah tanya sakit apa. So it's difficult for them untuk start the process of sharing with them. And so don't be judgmental, and even those, for example, and you come across patients yang ada sexual promiscuity, patients yang works as prostitute ke, for example, or patients yang murtad ke, and patients yang liberals ke, whatever their background is, when it comes to an illness, when it comes to professional contact, we are dealing with somebody who have illness. Okay, so outside is a different story, and your principles is a different story, and tapi you do not mix that up, okay, in a way that makes you become judgmental. And so, for example, a patient to a certain religion, you ask detailed history, and kalau different religion, you go just ala kadar je. So that's what it means by being judgmental, prejudiced, and dismissive. Okay, so it's important for you to have this particular knowledge. Now, if you think about psychiatric interview, this is probably one of the things that we would imagine, but let me get it straight to you. We don't do this. Okay, tak ada patient saya yang terbaring dekat klinik, melainkan memang dia datang catatonic ke, ataupun dia ada medical problem, we clerk them in the medical ward, then they might be interviewed while lying. But this was not the case these days anymore. Okay, so this was what psychoanalytic or psychoanalysts used to do back in 100 to 100 years back. So there are three parts that we'll go through in order to understand psychiatric interview. Basically, you have to know what you need to do before the interview, how to start the interview, and continuing the interview. Right. You might not be doing any of this for the next 3 weeks because you won't see patient face to face. But hopefully you have some of these basic ideas about psychiatric clerking in mind. Keep it somewhere safe, and then once you get into 5th year, you go back to the ward and clinic, inshallah next year. Stick back to this and this principle that I've taught you this year. Okay, and then ending the interview. Okay, so where do you clerk patients? This is basic principle. So the ideas is, number one is you don't want to be too close to the patient where they become uncomfortable or putting you at risk of if anything happen. Plus putting patients at risk if anything happen. And so jangan ingat patients dia boleh agresif, Interviewer juga boleh jadi aggressive. In case you yourself have emotional problems, emotional issues that you do not manage well. And for example, patients to become abusive, and for example, patient in manic, and so patient in manic or psychotic can be abusive, not because they are abusive, tapi they maybe have troubles in regulating their behavior. Or patient with antisocial behavior, psychopath, for example, and they might be needed to be interviewed in the psychiatric setting, and they might do something yang threatening to you, and so you might retaliate back, and patients cursing you, for example. So if you don't control your professionalism, and patients might be a danger to you as well. And kalau you besar patient kecil, and patient lagi takut you daripada you takut patient, tapi that can happen as well. So normally we sit in the 90-degree angle there so that we don't have direct contact with the patients. I mean direct face-to-face with the patient, but it also depends on the areas that you're working in. And kalau saya, normally I'll sit next to the child, and then parents will sit right in front of me, and takkan parents tak duduk sebelah saya kan? Okay. But sometimes in my clinics, I sit with the patients in my playing area and duduk dekat kursi mainan, and parents duduk dekat desk area. So depends on your context. And sometimes we walk with the patient, and especially kalau in the ward, and sebab kita nak tengok patients walking, kita nak tengok patients punya psychomotor activities. So it will depends on your aims of the interview at that particular time. So before starting the interview, so if you imagine you go to the ward, the patients duduk dekat waiting area, so you approach to them. And so what do you need to do before you start the interview? So 3 things that you need to know. Number 1 is you have to get patients comfortable, and so make sure that patients are comfortable before you get patients to interview, because clerking patients with psychiatry ni lama, okay, and kalau new case that may up to 1 hour. And the other day my patients yang catatonic tu, my MO was sorting things out for almost 3 hours, and sebab patient tak nak bergerak, tak nak cakap, so it is a long process, long due process. Second one is arranging to take notes if you think you need to take notes, and so you have to understand as well the context of the interview. And so kalau patient tu suspicious, for example, patient tu ada delusion, patient tu psychotic, so you might not want to take notes in front of the patients, because patient might think that you are conspiring against them, for example. And so there are things yang you need to know before you get to see the patients and before you start the interview process. And kalau patients tu depressed, for example, and kalau you keep on focusing on writing, patient might not feel that you are helping them in any way, so they might want to stop the interview. And tapi if you focus on the patients, tengok mata dia, ada proper eye contact, body gestures yang menunjukkan you are trying to understand the patients, and patient will be more comfortable with you. And the last one is to ensure safety and make sure that you are in the situations where, in case if there's anything happen, and you can ensure that your safety. And so do not interview patient in isolated area where there's no one will be able to see you with the patient. And kalau you perasan psychiatric clinics, and you might not be in one, tapi kalau in psychiatric clinic, there's always 2 rooms. Okay, it's important to have 2 rooms. Why? Because this is where, if anything happen, you have escape, and patient escape. And I have experienced patient in the past where patients come to the clinic bawa senjata. Okay, and so kita tak check patient kan, and sebab kita bukan airport, and tapi bila patients escalate, and dia nak ubat, and dia nak benzodiazepine, and kita tak bagi, and the patient threaten, dia kata, I carried knife in my pocket. And so these are the things that you need to be aware of. So not all patients with psychiatry are dangerous, but dangerous situation can happen in some occasions. You have to be careful. And in fact, when you're clerking medical, surgical patients, you have to you always have this in mind because you never know, especially if you're dealing with patients that you have never had experience or prior knowledge. And so, for example, you're working in ED in district hospital. Patients come in a drunken state, for example. You never know what a drunken person might do. And so maybe patients tu datang dengan injury to the fingers. So you nak stage patient. So you stage patient dekat storeroom because the rest of the areas are occupied. So you think there's no harm, I can do stage within 5 minutes. So you bawa patient dekat storeroom, you stage patient. And dalam storeroom tu ada all sort of things that can be used as a dangerous weapon. And you pula dalam bilik yang ada only one access, and patients are blocking the access because you are inside the interior aspect of the room. And so these are the things that might get you in trouble. And so you need to make sure that you are safe. Okay. And so there are some skills that you need to know when you are asking patients. And so we'll go through these in a minute. Kita stop here first for a short break, boleh ya?
Boleh, Doktor.
Boleh.
Okay. Kita stop 5 minutes and then kita carry on with the rest. Kita stop at 11 suku kan?
Betul ada.
Okay. Stop 11 suku. So kalau ikut jam saya 10:19, 10:20 lah. So kita start back 10:25, okay?
Okay, Doktor.
Thank you. Kita borak-borak pun dia recorded. Kalau yang in case ada students yang tak ada duit, apa options yang apa helps available Ada medium untuk you all voice up. Ke you all semua kaya-kaya? Sebab saya tengok student affairs ada collect duit untuk katanya buat food bank semua tu tak ada, belum ada lagi.
Pasal kita banyak dah food bank, ada daripada luar, ada sponsor makan, lepas tu ada daripada ni, banyaklah, ada Google Form suruh isi semua.
Okay, alright. So maksudnya anyway kalau ada orang yang memang betul-betul terdesak, there's help available lah.
Even kalau dekat mahalah ni pun dia pantry ada makanan lah. Orang kadang-kadang nak refill makanan kat situ. Ada makanan free dan letak dekat situ.
Okay, alright, good. So nak lemak je lah. So jangan takut untuk reach out for help if there's anybody ada keperluan-keperluan yang tidak dapat dipenuhi, just reach out, and you don't know what happened to you inside there. Kita duduk kat luar.
Gantung bendera putih.
Bendera putih pun kita orang tak nampak. Okay, alright, thank you. So kita sambung and so bila kita clerking and bila kita clerk patient, when we interview patient, it's not just about simply asking patients questions based on list of apa kita panggil list of symptoms or list of criteria yang ada, and you cannot go with the patient with list of listed questions and you just blurt it out during the interview, because interviewing techniques in psychiatry is different, and so you have to have different skills in information gathering. And so information gathering in psychiatry basically means your ability untuk understand patient experience and later interpret it into specific symptoms and signs related to psychiatry, and we call it psychopathology. You learn nanti kan psychopathology, mood apa, thoughts apa, memory apa, perceptions apa. And so these are some examples of information gathering skills yang ada. The first one is open-ended and close-ended. So this is, you all semua tahu kan, so open-ended boleh cerita tentang perasaan, so that's open-ended. Kalau close-ended, ada rasa sedih ke? And so that's close. So ada open, ada close. So in psychiatry, you need to have a good mixture of open and close-ended. And so open may be important at the beginning, and bila you nak decide which area yang affected, but once you dah boleh narrow it down to specific areas, you know these patients have major depressive disorder, so your next task is to exclude remaining differential diagnosis, so that is where your close-ended is important. Ada tak ambil barang terlarang, ada tak penyakit-penyakit tertentu, ada tak gejala-gejala hyperthyroidism, hypothyroidism, so that's close-ended. So you need both open and close. Right, listening is also important, and listening is where sometimes patient would tell you things that you did not ask. Okay, you asking about something else, but patient answered something else. But that something else might be actually useful for you, and even though that was not the thing that you want at the first place. And so listening is important. So for example, you were asking about patients punya sleep, for example. And tapi when talking about sleep, patients bercakap tentang, oh dah tu dia tak bagi saya tidur, dia kata jangan tidur, awak tak boleh tidur. And so kalau you were just focusing on the sleep, you might just ignore that bit. And tapi kalau you were listening well, you know, siapa pula dia tu? Then you might go on to that. And siapa yang bercakap tu? And rupanya patient have experience hallucination. So this is where listening is important. Facilitation is where you help patient to answer. And bukan maksudnya you answer for the patient, tapi you help patient to understand the questions and be able to answer it more closely. And for example, and contohnya you mentioned to patient, patient was having difficulty untuk expressing tentang suicidal thoughts, and so you facilitate by, and sometimes, and when I see patients like in your situation, they might have thoughts like wanting to end their life, for example. Have any of those come across in your mind during these last couple of weeks? So that's facilitations. You help them to answer, and without where in topics where they have difficulties. Another one is noticing and responding to verbal cues, and this is also important, like what I mentioned earlier on. And so patient give you hint about things. Contohnya patient mention, entahlah doktor, kadang-kadang saya rasa mati lagi baik lah. And so that bits of information is very important. So even though you were exploring about medical illness ke, family situation ke, social situation, but that verbal clues is important because suicidality is one of the things that you need to cover during psychiatric clerking. So maybe you can use that bits of information in order to explore about suicidality. And maybe you can use things like, and just now you mentioned about not wanting to live anymore. Can you share with me what exactly you had in mind when you said that? And ataupun more close-ended, and have you actually come across thoughts like wanting to end your life? And so these are the things that you have to include in your clerking. And asking for examples is also another way. And for example, patient mentioned that sometimes are worried about many things. And so you get to know what many things are, because sometimes the content of the worry will help you to understand different types of anxiety disorder. So you have plenty of anxiety disorder. Different anxiety disorder have different theme of worries. And so how do you know whether this is social anxiety disorder ke, specific phobia ke, post-traumatic stress disorder ke, obsessive compulsive disorder ke? You will not know until you understand apa yang go through in patient's mind. You have to give example. And you have to get patient to give you example in order for you to capture the essence of patient's punya thoughts. And so we don't read minds, even though people might think that psychiatrist works by reading patient's mind, but that's not the case. We read minds by interpreting what patients share with you. And so that's why information gathering through clerking is important. Okay, checking with patient, encouraging physician. So encouraging physician is where you need a better understanding of apa yang patients tell you. And so patient kata, dah lama dah, and saya rasa macam ni. And so dah lama tu is an open statement. So you need to be more precise. What do you mean? 1 week, 2 weeks, 1 month, 6 months? And because in psychiatry, duration is important. And so duration is part of your diagnostic criteria. So if you do not get to be specific with your timing, then you will have trouble justifying your diagnosis at the end of your clerking. So kalau in exam, for example, and kalau you tak bother about timing, you do not be precise enough about timing. So later bila you nak present your differential diagnosis to examiner, you will have trouble to justify yourself. And so for example, for schizophrenia, you need 6 months of symptoms. So if you don't bother to ask about duration, then macam mana you nak justify your schizophrenia as your option of diagnosis. Okay, so important to look into that. And also controlling flow of the pintu. Later nanti Dr. Nabil akan tunjuk examples of patients, many patients psychotic. Some of them will have trouble untuk keeping up with the pace of your interview. And so you think you have 20 minutes, but patients feel like they have to talk about one thing in 20 minutes. You have tens and hundreds of things you want to know within that 20 minutes, and tapi patient choose to talk about one topic for 10 minutes. And so you might be in trouble because you will not have enough time untuk cover important information for you to come up with diagnosis and differential diagnosis. And so you have to know skills and techniques untuk you control the flow in the interview. And so, for example, macam mana you nak mencelah, macam mana you nak capture one topic tu in a shot. And maybe, for example, kalau you tend untuk go open-ended, you will end up get open-ended answer. And tapi kalau you stagger your questions, ada some of the questions close-ended, then you might be able untuk dapat information yang lebih useful. For example, and patients ada 10 years history of depressive symptoms. Tapi you want to know what happened now, and so maybe the way you word the questions. So maybe you say something like, I know you've been feeling depressed for a long time, but I'm interested to know what really happened for the last couple of weeks. And so every time you ask questions, you go back to this. And so what happened to your sleep during these couple of weeks? And if you go open-ended, can you tell me about your sleep? Patient might go on talking about how his sleep was last year, how his sleep was 5 years ago, how his sleep was 20 years back. Then you won't have trouble. Then you won't have enough time to cover important information for current presenting complaint. So these are the things that you need to include in your history taking so that you'll be able to do better history taking. All right. So when you start the patients, important untuk you welcome patients by name, introduce yourself, explain the purpose of your interview, and talk about confidentiality. And so everything that we say during this interview is confidential. It is meant for our learning and teaching purposes. We will not disclose any of this information outside these contexts. And so it's important, and you have to abide to your pledge with the patients. And so jangan lepas plug patient bagi letak dekat Facebook. Oh, hari ni aku plug seorang patient, dia budak sekolah menengah daripada Kuantan, mak dia macam ni, ayah dia macam ni. Oh, sungguh menginsafkan. So don't do that. And even though you might be tempted to do so to share your knowledge and experience, but kalau patient tu baca, they will know, oh, this was not confidentiality as promised before. Alright, so start by asking patients' background and explain your postures, your eye contact, and everything is important, like I mentioned earlier. And open-ended questions is important in order for you to get information. So later you learn different psychopathology, and then you have to think about what are the ways of asking those questions. And so these are the things that you need to you gather, and bukan sekadar tahu, oh, depression, dia ada depressed mode 2 minggu, anhedonia 2 minggu, poor sleep, poor appetite, poor energy, psychomotor retardation, guilt, suicidality, hopelessness, worthlessness. So those are list of symptoms, but you also need to know macam mana nak transform that into questions, both in Malay and English. And so international students pun kena understand and how do we normally ask this in Malay, and in locals pun kena understand how do we ask this in English. Both would be valuable, and regardless of your situation, because it's not just for you now only, but later on you'll get different patients with different backgrounds. You need to also understand, and by knowing how to ask, you will know how to understand the diagnostic criteria better. So kalau hafal saja, you memorize just by heart, then you might not be able to really understand the concept of symptoms behind each of the diagnosis. Alright. So for example, you want to know mood, and so there are different way, and so maybe you can ask simple macam mana rasa kebelakangan, apa perasaan kebelakangan ni, ataupun boleh cerita tentang emosi Encik sejak akhir-akhir ini, ataupun apa yang berlaku dengan apa perubahan yang Encik perasan dengan emosi Encik bila masalah ini berlaku. So those are different ways of asking, but at the end of the day we want to know patient's emotions and mood during the designated period that you want to explore. Okay, and the rest is continue the interview and exploring, and you have to know where to ask open, where to ask close-ended, macam mana nak flow patients punya thoughts, and you have to have set of framework. And macam siapa yang, if you listen to my interview, given you example, and if you're looking into psychotic symptoms in psychotic patients, and follow through the order accordingly, and jangan 1 minute you asking about delusion, another minute you're asking about hallucination, another minute you're asking about sleep, another minute you're asking about mood, and so complete it according to cluster of symptoms, and then you will cover it more thoroughly without missing any important points. Otherwise, you will jumble up your history, then at the end of the day, your history will be chaotic. And so patients chaotic tak ada masalah, because patients is unwell, and tapi kalau patients confused, at the end of the interview, you pun confused, and start seorang dia confused, at the end of the interview, dua orang yang confused, then that's problematic. And so you have to have a thorough understanding about that. So what would you cover dalam history taking? So start off with patient's profile, and then presenting complaint, history of presenting illness. History of presenting illness basically things that have happened during the period of current unwellness. Okay, and so because sometimes in psychiatry, you have patients who have history of mental illness for maybe 10 years, 20 years. And so you don't want to go for 20 years to cover in HPI. So HPI, concentrate on current episode, most recent episode, most episode of relapse. So that's what you go through. Past psychiatric history are things in the past. And so first admission, second admission, third admission, things that happened in the past, you include and you cover that in the past psychiatric history. So basically you want to know how many admission, how many relapses, what happened each relapse, what precipitated relapse, and what happened in between. So those are the things that you want to know with regards to past psychiatric history. Past medical history, substance history, you need this because you need to exclude this as one of the definitions as well. Patient presented with mood symptoms, do not forget that mood symptoms can also occur in medical problem. Mood symptoms can also occur secondary to substance. So therefore, do not exclude this from your history taking. Family history, personal history, and then pre-morbid personality. Alright, so presenting complaints are the things that you want to ask with regards to what happened in the context of current situation that leads to patient's admission or presentation to the clinic or to the ward. So you want to know mode of referral, so who brought patients. So in psychiatry, patients can be brought by family, can be brought by police, can be brought by community nurses, community team, community secretary team, and can be brought by court, for example, can be brought by Jabatan Kebajikan Masyarakat. So you have to understand the context of presentation. So where is patient being seen, emergency, clinic, presentation status, voluntary, involuntary. So involuntary patients can come either due to risk issues, some, for example, patients suicidal, homicidal, aggressive, or involuntary can also occur in the context of legal procedure. And so, for example, patients in court, for example, and so ordered by court to be assessed by psychiatrists, that can also be a form of involuntary assessment. So voluntary, like any other patient who attended psychiatric clinic for assessment of their problem. So you start off with presenting complaint using symptoms that they describe in their own words. And so if patients have multiple problems, so use 2 or 3 symptoms to present your ideas during presentation that reflect most of your working diagnosis. Okay, so for example, patient mood symptoms pun ada, psychotic pun ada, sleep problem pun ada, aggressive pun ada, anxiety pun ada, everything ada. It is possible. But at the end of the day, after you gather all history, you need to make up your mind. Is this a case of psychosis, mood, or anxiety? So if this is a case of mood, then you highlight 2 or 3 mood symptoms as the presenting complaint. Okay, so this is important because later bila you present, you need to organize your information. So you club patient using whatever flow yang you choose to embark masa you club the patient. But bila present, you need to present it in an order that is outlined in a typical psychiatric presentation cases. And so kalau in year 5 clinical, you have 20 minutes with the patients and then 20 minutes for the presentation. So presentation tu will include 10 minutes of presentation, 10 minutes of discussion. So that 10 minutes tu is basically a summary of what you've interviewed in that 20 minutes. So you have to susun, you have to organize it in a way that will be easy for the examiner to understand your thinking process. So for example, you may start something like, so I interviewed Mr. X. Mr. X is a patient who was brought in by family members to psychiatric clinic with complaints of depressed mood, poor sleep, and suicidal ideation for the past 4 weeks. And so, even before you start the history presenting illness, those who listen to the history will get some. We have already some ideas that you will be presenting a case of mood disorder. All right, and then from there you start carry on with history of presenting illness. This is where you spend maybe roughly around 15, 20, 25 minutes with the patient exploring about what happened during this episode. And so you want to know the nature of the problem, what's the issues, mood, psychotic, anxiety, chronology of each symptoms, what start first, what develop later, the onset and duration of each of the symptoms. Onset basically means whether it comes gradually, abruptly, following a certain occasions or events, and then duration. Severity of the symptoms, okay, whether for example sleep, and so you can assess whether the sleep trouble has been there for a long time, 1-2 times, patient did not get enough sleep at all or get some sleep eventually. And so these are all the questions that you need to answer in order for you to assess the severity of the symptoms. So for example, patient with suicidal, you have to, suicidal ideation, you have to explore the severity of the ideation, whether it's just a plan, whether it's just a wish, whether there had been an attempt, whether there has been a steps taken in order to avoid people from knowing that the suicidal attempt taken place or not. So those are information that you need to gather in order for you to understand the severity of the symptoms. Degree of functional impairment, precipitating factors, the stressor, what happened biologically, psychologically, socially, spiritually, leading to the current episode. So if patients are depressed, it's not enough just to explore about depressive symptoms. It's also important for you to explore what leads to the, what precedes the depressive symptoms, because that is where some of management would probably lies. So for example, if you want to diagnose post-traumatic stress disorder, you cannot diagnose post-traumatic disorder without eliciting that there has been trauma happen. And so in that case, the stressor is important. Adjustment disorder, for example, you cannot diagnose adjustment disorder in psychiatry without understanding what was the things that patient need to adjust to, what was the stressor that leading patients to having trouble to adjust to that new environment. So in that case, the acute stressor is important. Patient experience drug-induced psychosis, for example. So you have to get a clear timeline between the onset of substance use and the development of psychotic and mood symptoms. So this is where your precipitating factors is important. Perpetuating factors are factors, things that happen around them that makes the problems prolong, propagate the problem. So for example, family problem, financial issues, poor coping, personality. So these are examples that make things difficult to be contained within short period of time. And perpetuate ni maksudnya dia memanjangkan, dia prolong the problems. Protective factors also another things that you need to look at. Factors worsening or improving and treatments trials. So at the end of history presenting illness, these are components and elements that we want to hear. And so we don't just want you to outline or have this patient presented with depression, patient experience low mood, no sleep, poor appetite, poor that, and then that's it. So you have to help us understand the context of this problem. Why this patient depressed? What makes it worse? What has happened since patient become depressed? What are the impairment of in patient's life whenever patient when patient has become depressed? And what are the things that have make it worse or make it better? And so these are the things that you also have to integrate in your presenting complaint. And so sometimes it's easier if you translate your history presenting illness into symptoms timeline, and because this is where you see the gaps in your history. And so you know, oh, this is the part where I don't know what happened. This is the part where things got worse. This is the part where things have changes. Okay, and so you will have some ideas about what really happened during this part. It's almost equivalent to macam kita jadi investigative officer. And so kalau you are police officer investigating a murder, you cannot have a gap in your timeline, because gap in your timeline basically means something could have happened there that might explain the whole thing. And so if you just use your judgment based on the limited information you have, you might catch a wrong person. Okay. Past medical history, and so this is standard, and you look into everything that might be contributing to the problem or might be the differential diagnosis of the problem. Medication history, nanti saya bagi slides ni, and so these are the things that you have to look at. Substance history, nanti later when you learn about substance, then you will explore more on what are the things that you need to know in order to explore patients with substance problem. The past psychiatric history, as I mentioned earlier, you want to know previous relapse, condition, previous treatments, what happened in between episodes, and these are the things that you want to include in your past psychiatric history. So family history is also another thing, and like any other illness in medicine, and some of them are related to family. But in psychiatry, apart from family illness, we also want to know family dynamics. And so siapa yang jaga dia dengan siapa, dia rapat dengan siapa, who are close to them, who are protective for them, who are they attached to, are also important things that we want to include in the family history. So this is an example of family tree. Personal history is basically patient's developmental history from birth until where they are now. Okay, so you want to know important things that happen in their life. And you might wonder kenapa nak kena tanya sekolah kat mana, dapat nombor berapa, kerja kat mana dulu, kenapa berhenti kerja. But these are all important information because, and this will be helpful for you to understand what are the risk factors in this patient. So for example, for somebody who's depressed with suicidal behavior, for example, so one of your differential diagnosis might be a borderline personality disorder. So in order to understand borderline personality disorder, you have to understand about the upbringing, childhood, traumatic experience in the past, past self-harming behavior, relationship in the past. And so this is why your personal history become relevant. So this is one of the reasons why psychiatric history become lama. And kalau you tengok your seniors punya case presentation ke protocols, case write-ups, banyak benda yang ditanya because we need to know all of those in order to formulate the case better. Okay, so social history, forensic history, patient has any history with legal system, And last one is pre-morbid personality. And so pre-morbid personality is where you want to understand patient's background, patient's conditions, patient's character, in order for you to understand more about patients. So there are two reasons. One is because you want to exclude personality disorder, and number two, you want to exclude personality factors as the contributing factors. So for example, somebody who are anxious might have obsessive compulsive personality disorder, perfectionist personality, avoidant personality, anxious dependent personality. And so you will know this by exploring patients' pre-morbid personality. So you want to know patients' characteristic, how other people describe him, patients punya religious background, patients punya hobbies, interests, patients punya methods of coping, and it will give you understand about patient's characteristic, whether it's normal, whether it's pathological. All right, and at some point you might be able to, you might come across problems in the interview or challenges. And kalau medical students selalunya dia kata, patient tak nak cerita, patient tak nak cakap, patient guarded. So that's one example. And patients guarded where patients do not want to disclose information, which is understandable because they don't know you, and you come and go, and they might not be comfortable talking about personal experience, very unique life problem to nobody that they know. And so some patient might be feeling that way. It's understandable. Some might not, but you have to know macam mana nak you react. And so for example, anxious patient, and patient yang tak pernah masuk ward psychiatry, they might be very traumatized by what happened, and nampak ada drill lah, nampak ada patient ni shouting dan sebagainya. And so sometimes what we can do adalah help them to normalize. And it's okay to feel that way. I can understand why you feel that way. If I am in your situation, I might feel anxious as well. It's common, especially when we experience something new to us. And so we help them to normalize the feelings. Uncooperative patients, you also need to understand, and you work with a patient's own interests. And so, for example, if I give you an example, patient who refused to be admitted, and so reluctant to say anything because patients were so fearful, patient was so irritable towards family member, and saya tak nak cakap apa-apa, and apanya bukan saya yang salah, dia orang yang salah, bukan saya yang gila, dia orang yang gila, dia orang yang masukkan saya dalam buat bla bla semua tu. And so macam mana, how can you get information from patient kalau patient tak cooperate? And so one of the way is you work at patient's own interest. And so for example, and kita maybe we can say something like, I understand that you feel furious about what happened, and I understand that you don't want to be here, and you want to go out as soon as possible, but and in order to help you to go out of this ward, we need to first understand what happened to you. We need to establish whether you are at any point well or not well. And so so I can only do that if you give your cooperation to me. And I know you don't want to be here, but why don't you just spend some time talking to us and share what your thoughts are, what happened from your point of view, so that we can make up our mind whether you need to be here or you can go home. Okay, so if you frame it that way, patient might be more comfortable in sharing with you because they know that you are working with them instead of against them. Okay, so that's one example. So other problems like patients who have patients who are dominating the interview, you tak sempat nak tanya, patient dia cakap, that's also another example. Nanti you learn about it in you talk about bipolar mania. Social conversation is sometimes you come across patients yang minta nombor telefon lah, and puji-puji you lah, dia borak-borak, and you want to club patient to get information, tapi instead patients yang interview you. And so that can also happen in some interview. Or you have quiet patients, over talkative patients, and disturbed patients, and so these are the things that you might come across during clerking. So ending the patient, jangan ending the patient, ending the interview might you have to also have some framework, and so remind the patients the interview is almost finished, and maybe ask patients something like, ada benda-benda tak yang cik rasa penting tapi saya tak tanya. So this is also important, and so that you don't miss out anything important. You might think that you have covered everything, but patients might think there are still things that they want to share with you. And so important untuk end the interview with this kind of questions, and give opportunity for patient to ask any questions. If, for example, you are students in the ward, as patient tanya, bila saya boleh balik ni? Saya nak balik ni. And so what you can do is simply by being honest. Minta maaf, dan saya pelajar perubatan, saya tak terlibat dengan perawatan, cuma saya dekat sini untuk belajar. So saya tak ada kuasa ataupun tak ada jawapan dekat soalan cik. Mungkin cik boleh tanya dekat doktor yang merawat cik. So be honest. So jangan, tak apa, saya rasa saya tengok cik ni tak lama ni, 2 hari lagi balik lah ni. Jangan mandang-mandang lagi kan saya saya suruh you ganti patient kat ward. Saya bagi patient balik, you duduk kat situ. Thank the patient and the family. And then kalau in psychiatric contact, in clinical contact, kita kena end dengan treatment plan. So what happened next? What happened from here? So in exam, you have a short case, masa 5th year nanti, 20 minutes. So how do you spend that 20 minutes with the patients? So introduce yourself and people around. And so explain who you are, and show confidentiality. So these are the things that we want to look for. Remind patient that you only have 20 minutes, time is limited, so you might interrupt at some point in order for you to gather important information for that particular 20 minutes. Explore patient's background, explore patient's chief complaint, focus on history of presenting illness. So you have 20 minutes, so 15 minutes should be enough in order for you to get important information for HOPI. So for short case, we do not expect you to explore personal history, past psychiatry history, past medical history, because we know it might not be enough for you. And tapi your HOPI should be complete. And so look back at my slides on HOPI, and so those are the things that you need to include in 20 minutes. So if you have depression, and so 20 minutes you need to spend time untuk gather symptoms, understand stressor, understand impact, and exclude other contributing factors, assess risk and suicidality, and so that should be sufficient in 20 minutes. And mungkin bunyi macam banyak benda, and tapi if you practice enough, you've seen enough patients, hopefully you'll be able to execute this within 20 minutes. At the end of the day, within that 20 minutes, we expect you to come up with at least working diagnosis and differential diagnosis. So that's where you need to also understand and explore other relevant information pertaining to that particular provisional diagnosis. So kalau patient presented with depressed mood, so of course your working diagnosis is major depressive disorder. Tapi remember, kalau you ingat balik my circle tu, and dalam depression and around depression, bukan ada major depressive disorder saja, and ada other aspects of diagnosis as well. And ada pervasive depressive disorder, ada adjustment disorder, and ada anxiety disorders, comorbid, ada substance-induced mood disorder, ada schizoaffective, ada bipolar depression, ada medical causing, ada medication-induced depressive disorder. And so how do you know whether this is MPD or the rest of the things that I mentioned earlier? Is by excluding and including those information dalam you punya HOPI. So you tanya lah. And so for example, kalau you nak exclude substance, senang aja. You have to explore tentang substance. You nak exclude medical, you have to ask 1 or 2 questions pertaining to medical. And so jangan concentrate simply on depressive symptom, lepas tu you rasa macam dah tak ada nak tanya apa dah. Okay, and so and then so after 20 minutes, that should cover most of the things. So this is what expected to you in your showcase. We'll mark you based on 3 components. Number 1 is your interview techniques. Number 2, your presentation of the case, your ability to analyze and elicit psychopathology, elicit mental state assessment, and then your diagnosis, differential diagnosis, and management. So these are the 3 things that we look whenever you were given a short case. Sama ada end of block assessment and ataupun final pro examination. Okay, so key message dia adalah focused history taking will ensure proper diagnosis and management. Good interview techniques akan fuel smooth history taking. And we need good empathy and good listening skills, and because they are therapeutic for patients as well as to you as well. And do not forget that you need to respect patients as human being and not a diseased organ or subject of posting. Okay, so if you remember these four basic principles, and you know where to start, and the rest is about experience. Okay? The rest is about experience and exposure. I know it's a bit orang kata raw in the sense that you probably know how it's done, but nak buat tu tak tentu lagi boleh. And tapi just keep that in mind first. In more time, insyaAllah, opportunities ahead, you'll be able untuk explore. Kalau dulu-dulu masa year 4, you'll still be given a chance to go to the ward and plug patient. I'm not sure macam mana coordinator buat this year untuk case presentation. Sama ada akan ada recording session ke, ada interview ada patients, simulated patients, I'm not sure. And tapi hopefully you get some opportunity untuk learn how to apply knowledge that I shared for this particular topics, inshallah. All right. Any question or anything you want to share? Any comment? You all punya Zoom university provide
Maksudnya?
Ini personal account ke atau each batch ada account dia sendiri ke macam mana?
Saya yang ni kurs university ni, tapi yang account sendiri kot, senang.
Okay. Memang boleh fit 150 orang
Oh, yang tu based on host.
Boleh Doktor.
Boleh. So any questions? Do you have ideas now how it's done?
Doktor, saya ada soalan.
Satu.
Saya ada Doktor, contoh kan, kalau kita datang dengan banyak complaints, kan kita nak classifykan dia sama ada psychosis, mood ataupun anxiety. Kadang-kadang ada komplain tu yang agak subjektif, yang saya tak tahu dia nak letak dia dalam mana. Contoh let's say macam insomnia, saya nak letak dia dekat mood disorder ke, saya nak letak kat anxiety ke? Itu satu. Lepas tu yang kedua untuk psychiatry, boleh tak saya nak tanya doktor, ada tak list macam disorder yang macam wajib kita tahulah at least as a clinical undergraduate?
Alright. So the first question adalah macam mana nak decide the presenting complaint tu under which area. Sebab tu, walaupun generally speaking, the way we understand presenting complaint adalah apa yang patient cakap bila kita tanya kenapa datang hospital. Tapi saya punya approach slightly different. Bila kita tanya kenapa dia datang hospital, patient akan cakap apa benda yang dia nak cakap lah. Dia cakap sebab mak dia hantar ke, dia cakap sebab dia tak boleh tidur ke, dia cakap sebab dia tak boleh nak buat kerja ke. Tapi that is not actually presenting complaint to me. Okay? So presenting complaint is actually apa yang sebenarnya drive that problem. And so sebab tu, you can only conclude apa patient punya presenting complaint after you spend some times and at least 5-10 minutes untuk dia describe dia punya underlying problem. So I give you an example. So patient start saying that saya tak boleh tidur lah doktor. Okay, so fair enough, sleep is what drive them to come to the clinic. Seminggu, 2 minggu dia tak boleh tidur. But sleep problem alone is very rare as a cause of problem that patients come to psychiatric clinic. There must be some other issues behind it because sleep ni biasanya sama ada dia one of the diagnostic, one of the criteria or one of the symptoms under another problem, contohnya depression. Mana dia ada depression, sleep tu salah satu dia punya problem, ataupun dia ada psychiatric problem yang lain, the psychiatric problem tu menyebabkan dia tak boleh tidur. And contohnya dia ada anxiety, dan setiap malam dia fikir, menyebabkan dia tak boleh tidur. And so sebab tu, jangan terus conclude, patient ni datang sebab dia tak boleh tidur. Tapi start off with open-ended question. And so dia punya cara dia macam you nak tangkap ikan lah, tangkap ikan. And you tak boleh pancing sekali tu dapat. And you kena decide area mana dulu, fokus kat area mana, guna jala ke, nak guna jaring ke, you nak guna bubu ke. And so you have to have strategy before you catch the actual things that you want. And so what you do adalah you just get them to explore. just get them to to explain. Okay, so boleh cerita apa yang cik maksudkan dengan masalah nak tidur. So dia akan cerita, oh saya tak boleh tidur, bla bla semua tu. Okay, and then explore selain tidur ada tak masalah-masalah lain ataupun ada tak apa-apa yang mengganggu encik yang menyebabkan encik tak boleh tidur. So still open ended. Kita tanya apa, what question kan. Ada pun kita, oh adalah doktor, saya rasa saya tak ada tidur ni sebab saya banyak fikirlah. Okay, so then you dah nampak sikit dia punya association. Okay, so boleh cerita apa yang cik fikirkan. And so saya rasa bersalah doktor sebab saya ada buat salah. Okay, so dia cerita pasal guilt. And so maknanya from there you akan dapat layers and layers and layers information. So macam tu psychiatry, you kena sabar. And kalau you harap within 5 minutes you boleh in and out patient, and macam you buat posting lain, maybe tak boleh. And kalau orang accident patah kaki, maybe you boleh you boleh terus settlekan management dia within 15 minutes and tanya-tanya sikit sambil check punya kaki ada circulation ke tak, terus hantar pergi x-ray, terus come back treatment. Tapi in psychiatry tak boleh, unfortunately, and because kita kena ikut dia punya stages. That's the challenge in psychiatry. Depends lah, you nak tengok dia as a challenge ke ataupun yang dia tengok dia as problem. Itu satu. Daripada situ, bila you dapat information yang more clear, baru you letak dia bawah basket apa. Itu satu. Yang kedua, itu soalan kedua tadi. Oh, apa list of symptoms? Okay, so untuk year 4 and year 5, basically you tengok list of seminar and lectures yang ada tu, itu yang major one lah. And so maknanya you, in term of yang apa yang you kena tahu untuk exam, theory part, semua tu. So you ada seminar on child, maknanya child you kena tahu sebab dia akan masuk exam. Dia ada seminar mode kena tahu sebab dia masuk exam. Teori ni teori. Dia ada you ada seminar on delirium kena tahu. Seminar on dementia kena tahu. Sebab these are topics yang will be covered dalam you punya theory exam. Tapi clinical ni berbeza sebab you akan fokus on patients yang ada. And so psychiatry ni dia luas daripada budak kecil sampai orang tua. And tapi untuk clinical and fokus kita adult mental illness sahaja. And so adult mental illness ni dah boleh narrow it down dah. And so most of them, majority akan present dengan mood disorder, anxiety disorder and psychotic disorder. And jadi those are important areas yang you kena cover lah. And so kalau you tak ingat diagnosis yang rare macam dissociative disorder ke cyclothymia ke yang jarang-jarang tu tak ada masalah. Fair enough. Because you won't get it in the exam anyway. You won't get clinical short case questionnaire rare. Tapi kalau you tak tahu MDD, tak tahu panic disorder, tak tahu GAD, still tak faham schizophrenia, still tak faham schizoaffective, bipolar, then you are in trouble. And because those are the common presentation. Regardless where, hospital mana, tempat mana, area mana you bekerja, and majority patients, outpatients are mood disorder, anxiety disorder. Majority inpatients are schizophrenia and bipolar. And jadi kena tahu, kena master those dulu. So macam mana nak master banyak sangat benda? Start simple dulu. Pertama, faham psychopathology dulu. Maknanya kena faham delusion maknanya apa, contohnya apa. Hallucination maknanya apa, contohnya apa. Panic attack maknanya apa, contohnya apa. So start with that first. Yang kedua, faham diagnostic criteria. So nak faham diagnostic criteria ni, kalau you baca DSM, kalau you baca DSM, you akan rasa macam you tengok perlembagaan Malaysia. Very body, banyak semua tu. Tapi saya dah ajar dalam my lectures and how to approach it. Tengok apa? Tengok diagnostic criteria, tengok duration, tengok exclusion, tengok function. Untuk diagnostic criteria pula, try untuk conceptualize it. And so contohnya major depressive disorder ada 9. And so macam mana nak ingat dengan mudah, you categorize the symptom. Anxiety disorder ada banyak symptom, macam mana nak categorize it. Schizophrenia ada 5 symptoms, macam mana nak categorize it. So for each symptom tu, kena ingat maksud dia dengan contoh. Maksud dengan contoh. So contoh, schizophrenia, positive symptom. Positive symptom, contoh dia apa? Contoh dia delusion. Delusion maksud dia apa? False fixed belief unshaken by false fixed belief unshaken despite contrary evidence, not in keeping with one's social or cultural background. Definition. Contoh, delusion of piscatory, delusion of grandeur. Contoh, passion rasa ada orang nak bunuh dia, passion rasa dia ni Imam Mahdi, passion ni rasa dia Sultan. So, bila you ingat macam tu, layer by layer, baru you boleh faham. Memang banyak, tapi start somewhere. Macam you menghafal Quran ke, macam you belajar medical ke, macam you buat apa-apa, semua akan start with rasa banyak. Tapi start layer by layer. Macam you mengemah rumah lah. Dan kalau you duduk kat tepi tangga macam banyaknya benda aku nak buat, 3 minggu you boleh buat macam tu, tak siap satu kerja pun. Jadi psychiatry pun macam tu juga, banyaknya benda nak kena hafal psychiatry. You pun duduk 3 minggu mengandung macam tu. Tak siap pun, you start somewhere lah. Dan macam nak masuk rumah kan, aku nak start clear sinki dulu lah. Clear sinki, at least sinki settle. So psychiatry pun macam tu juga. Ada banyak benda, settle satu-satu dulu. And hopefully at the end of third week, you dapat knowledge. Buat nota baik-baik, and jangan just copy paste daripada Google sahaja. Buat nota baik-baik supaya later bila year 5, you tak payah start from scratch. And tak ada you macam ada traumatic brain injury macam benda aku belajar selama ni, tak ada. And you have some foundation to go with. Okay lah, dah 11 suku dah. Nanti you'll see me somewhere. Bila? Rabu tak ingat. Okay.
Rabu seminar.
So Rabu ada seminar dengan saya. Rabu topik apa? Child.
Child.
Okay, alright. Thank you so much. You are the next class ya. Alright. Okay. Assalamualaikum.
Waalaikumsalam.
Thank you, Doctor.
Thank you, Doktor.
Thank you, Doktor.
Thank you, Doktor.